afternoon to our respected teachers and seniors. Today my topic of presentation is versatility of LOCO-REGIONAL flap for reconstruction of fingertip defects. First introduction, LOCO-REGIONAL flaps are versatile flaps for fingertip defect reconstruction due to their ability to provide durable coverage with minimal donor site morbidity. Often in a single surgical step operation could be done. They are particularly useful for a range of defects including those that are volar oblique, large lateral or medial defect and circumferential degloving injuries. Now, objective of my study to study the reliability of LOCO-REGIONAL flap for reconstruction of fingertip defects, to study the overall postoperative outcome in terms of flap survival, operative time, donor site morbidity, flap complication and patient satisfaction. To achieve a reliable and stable reconstruction with a local flap due to its simplicity and effectiveness. Now, inclusion and exclusion criteria. Inclusion criteria includes traumatic finger injuries involving fall, nail bed and volar defects unsuitable for primary closure, patient requiring coverage via LOCO-REGIONAL flap techniques, and willingness to comply with follow-up protocol. Now, exclusion criteria: crush injuries involving multiple fingers, underlying malignancy, peripheral vascular disease. So, patient selection and methods between 2023 to 2025. 30 patients with soft tissue defect and bony defect involving fingertip were reconstructed with LOCO-REGIONAL flaps. Average age of the patient was 43 years, 19 to 67 years. A total 19 male patients and 11 female patients were included in the study. 15 cases of soft tissue defects and bone involvement at the fingertip and the lateral side, and 15 in the medial side. So, surgical techniques. Dimension of the fingertip defect was measured and a provisional flap design was then drawn. Patients were evaluated preoperatively and then flap selection was based on defect location, size and orientation. 3 types of LOCO-REGIONAL flaps were used. VOI advancement flap. This flap is commonly used for transverse and oblique fingertip defect, allowing for advancement of soft tissue to cover the defect while preserving the length and sensation. Canard flap, elevated from the canard index and advanced or transposed to volar oblique injuries, providing a well-padded and durable coverage. Now, cross finger flap, this two-stage flap is useful for larger defects or when volar flaps are not feasible, involving harvesting skin flap from the adjacent finger. Careful and meticulous dissection was done around the pedicle. Flap was raised and made completely. After deflating the tunicate, once the flap perfusion was satisfactory, it was transferred around its pedicle into the defect. Donor defect was closed either primarily or by full thickness skin graft. After all flaps were performed under regional anesthesia with tunicate control, donor site were primarily closed or skin grafted as needed. Post-operative dressing were applied with care to avoid flap compression. Post-operative care and follow-up. Patients were mentioned for flap viability, complication and rehabilitation. Sutures were removed by date into 14. Follow-up assessment were done 2 weeks, 1 month, 3 months, 6 months post-operative. The flap design of the canard flap, flap design of VOI advancement flap. Now result: 30 patients with soft tissue and bony fingertip defects were operated with this method. Dimension of soft tissue defect were ranging 1.2 cm square to 6 cm square. All the patients tolerated the procedure well. Average duration of surgery was 2 hours with maximum duration 2.5 hours and minimum duration 1 hour. 3 patients in this series developed partial flap necrosis less than 1/3 of the flap, managed by regular dressing followed by FTSG. 1 patient developed complete necrosis who required another flap cover. All the patients showed good functional recovery and early return to the ward, excellent aesthetic outcome and minimum donor site morbidity. Now the first case, picture of the defect and canard flap reconstruction. Follow up after 21 days of the flap detachment and after 1 month. This is the post-traumatic induced fingertip defect with exposed bone, reconstructed with VOI advancement flap, planning on volar side and another on dorsal side, reconstruction with VOI advancement flap, and follow up at day 14. Another post-leg and fingertip defect reconstructed with canard flap, follow up after 21 days of flap detachment and after 1 month. And post-traumatic fingertip to be reconstructed with digital active perforated flap. Follow-up after 1 month. Advantage, possibility to cover the defect with tissues having similar quality, no need to sacrifice the major nerve and vessel, minimum donor site morbidity, reduction of operating time, single stage reconstruction and cell set coverage, satisfactory aesthetic appearance can be achieved, doesn't require setup of microvascular surgery. Disadvantage, potential for stiffness, donor site morbidity in the form of scarring, pain and limited range of motion, flap thickness depending on the type of flap and size of the defect. The flap may be thicker than the original tissue, potentially affecting the dexterity of movement. The conclusion, loco-regional flaps are a valuable tool in fingertip reconstruction due to their versatility, ease of use, ability to provide durable and sensed coverage with minimum donor site morbidity. However, surgeons must carefully consider the specific defect, patient factor, and the potential for complication when choosing the most appropriate flap for each individual cases. Thank you. Thank you. Thank you.